Well, thanks everyone for joining us. I'm just managing the technology here, so assuming everyone can see my slides, I'm going to take you through the bit of classification diagnosis of preeclampsia and other hypertensive disorders in pregnancy. Now, the learning objectives for this talk are three things. Hopefully by the end of the talk, you'll be able to identify women who are at risk for preeclampsia. Secondly, how to diagnose the different types of hypertension in pregnancy, because it's more than just preeclampsia, of course. And lastly, what diagnostic tests should be used and why, and when nothing will be too fancy in those tests. Let's go through a case first of all. So this is a 25-year-old woman in her first pregnancy with excellent blood pressure at 8 weeks, and she's having shared care, and she's an otherwise well woman. At 26 weeks, she develops blood pressure of 140/90. She's well, her baby's well grown, and she's got good fetal movements. And so in all of our minds, the question first of all is, does she have hypertension? It kind of looks like she does, but I'll come back to that. What should we do at 26 weeks? And what is actually wrong with her? Now, in regards to the question of hypertension, it of course depends how we measure the blood pressure. That's the obvious statement. And I put this up to show you a study that Greg Davis, who'll speak later, published with us, and showed that if you are going to use a device which is a liquid crystal mercury-free sphygmomanometer, it's far more accurate in pregnancy, both normotensive and hypertensive, than is a well-validated home blood pressure monitor, the Omron device that many of you use in your practices. Not to say that device is not usable, it is, but it's not as good as sphygmomanometry in terms of its accuracy for blood pressure. So that's the first point to make in determining hypertension. And once it's been taken carefully, with the patient seated and with the correct cuff size, a systolic pressure of 140 or above, or diastolic pressure of 90 or above, is considered to be hypertensive. Now we need to confirm that. If the first readings you get are in these high levels, 160 or 110, then that's got to be confirmed within 15 minutes. And if that's true, that woman needs to go to delivery suite and be further assessed and managed in hospital. But for the less severe cases, it is reasonable to repeat readings over a few hours. Now, I know in general practice that's not exactly possible, so it comes down to a case of a few repeat readings over the time that you've got, using a liquid crystal sphygmomanometer. If you don't have something like this, and I'd urge you to get them because they're actually quite cheap and usable, then try to use a validated automated device, but don't use an aneroid device. They've got quite a few errors in pregnancy. These are a list of validated home blood pressure monitors, and therefore monitors that you could also use in your surgery, the automated ones for pregnancy. These have been validated according to a few different techniques internationally. And this will be available on the YouTube later on after these talks. So you'll be able to come back to get those brands that are useful. So they're reasonably validated. So what about this patient again? Well, her blood pressure is repeated and it's 142/90. So we're thinking that there's true hypertension. And in your surgery, you do a urinalysis which shows 1+ of protein. Now, obviously everyone is thinking she's got preeclampsia at 26 weeks, but I want to make a point about the proteinuria. 1+ of protein, you literally can toss a coin as to whether or not this is true proteinuria or whether it's a false positive. The dipsticks are deliberately set to be oversensitive so that cases are not missed of proteinuria. But in pregnancy, and particularly when diagnosing preeclampsia, it's such an important issue that we really need to have other ways of assessing that. So first of all, I don't know if you have an automated urinalysis device in your practice that the nurses can use or anyone can use there. They're moderately cheap and they're quite accurate, and they've been shown to be more accurate than visual dipstick urinalysis. But if not, a simple dipstick urinalysis is fine. If there is proteinuria, 1+ or more, then that needs to be confirmed with a protein-creatinine ratio, because that's really the only way of knowing if this is true proteinuria. And if it's above 30 milligrams per millimole, then that's abnormal for pregnancy, and we're considering this woman to have proteinuric preeclampsia. Conversely, a negative dipstick can generally be accepted and doesn't need further investigation. But I want to make the point that proteinuria is not required for a diagnosis of preeclampsia any longer. 3/4 of cases will actually have proteinuria, but 1/4 will not. So let's think a bit more about preeclampsia. Why do we do the tests that we do? And these are largely tests that can be sent off when you see the women, even before they get sent into hospital. Now, just to go very briefly through some of our understanding of preeclampsia and hence why we do these various tests. In normal pregnancy, the spiral arteries get invaded in the decidua by trophoblast. And this turns the arteries from a small, narrow vessel into a very large capacitance vessel. That means it can carry a lot more blood flow. It's effectively turning an artery into a vein. In preeclampsia, that doesn't happen as well, and sometimes not even at all. And so you're left with a narrower blood vessel, but more to the point, you're also left with smooth muscle coating that can vasoconstrict in response to various substances like angiotensin II and so on. Now, there are a lot of reasons why this happens. Some cases are genetic. In some, there are particular antibodies. In some, there are cytokines, which either might be primary or released secondarily to this problem. And the other thing we've learned recently is that syncytiotrophoblast particles coming from here actually get into the maternal circulation, even in normal pregnancy, and are circulating. Now, we used to think that was just a very interesting finding, but we now know that these microparticles can produce a lot of factors, some of which are these so-called angiogenic factors. And I'm going to come back to these in just a moment. So there are maternal predispositions, and I'll come back to that from the clinical aspect in a moment. There's the problem that happens in the uterine vasculature that we've just mentioned. And one way to think about this in general is you've got an ischemic placenta. Now, it might be because the vessels didn't form properly, or it can be for other reasons as well, but you end up with an ischemic placenta. And what that does is it releases this factor called soluble FLT1, which used to be just an interesting factor, but it's now something that is measured in laboratories all the time. This soluble FLT1 mops up vascular endothelial growth factor in the circulation and placental growth factor. These factors are needed for proper vasculature development and also to maintain the integrity of our vasculature. So, for example, if you don't have enough of this VEGF, then you can vasoconstrict and you can get proteinuria and you can get various capillary changes in the glomerulus. And so when this happens due to the ischemic placenta, suddenly the mother's blood vessels are sensitive to a whole lot of factors like angiotensin II and so on, endothelin and so on. And if we go down the scheme, so all of that's happened, what are we left with? Well, we're left with target organ damage. So in the peripheral vasculature, we get high blood pressure because of the vasoconstriction. We get a capillary leak because of the endothelial disruption, and that's going to cause edema. We can get platelet activation because of this endothelial dysfunction, and that's going to cause a low platelet count and sometimes DIC or clotting. In the kidney, we get proteinuria because there's disruption of the endothelium. We can even get renal impairment because of the reduced blood flow with vasoconstriction and so on. In the liver, we get abnormal liver function. We can even get liver rupture if the ischemic liver goes on bad enough. And in the brain, we get cerebral edema, and we all know about eclamptic seizures and the reversible encephalopathy syndrome associated with severe blood pressure. So we've got all of that. Well, how do we detect that? Well, first of all, we're going to measure the blood pressure to reflect this peripheral vasculature abnormality. We're going to measure the hemoglobin. If that's high, that's a reflection of plasma volume contraction. And we're going to measure the platelet count as a marker of platelet activation. How do we detect the kidney abnormalities? We'll measure the serum creatinine. Anything above 90 in pregnancy is abnormal. We measure the uric acid. We'll obviously do the urinalysis, and we've already talked about the protein to creatinine ratio. How do we know if the liver's affected? One of the signs is epigastric and right upper quadrant pain. Don't assume this is indigestion. Assume in a hypertensive woman that this is liver abnormalities. And of course, the transaminases can be abnormal as well. And how do we detect problems in the brain? We look for clonus. No longer do we consider hyperreflexia alone as a problem. They have to have clonus. We look for severe headaches and visual scotometer. And of course, the major issue is from the placenta. So what we're very interested in is what's happening with baby. Is baby growing appropriately? What's the abdominal circumference, the amniotic fluid index, and the Doppler blood flows? So I hope you can see why we do some pretty simple tests and some pretty simple clinical examinations, how that is based upon the physiology that we understand of preeclampsia. Now, what about this woman? Well, she has mild hypertension. We confirm that she's truly got proteinuria. Everybody's got a story to tell in pregnancy, and so her friends tell you to make sure you measure tests for these angiogenic factors, the soluble FLT1 and PLGF. And these are now readily available and are measured in many obstetric units. They're not measured in our unit deliberately. So should we measure this ratio? You're going to get different stories, and that's absolutely fine. And they're largely based on a study published in the New England Journal of Medicine that took a large number of women who were suspected of having preeclampsia. This ratio was done. If it was below 38, it was considered that they were unlikely to develop preeclampsia, and it was used as a rule-out test for preeclampsia over the next week. It later got extended to be a rule-out test over the next month, and this is where it gets a little more scary, because if you actually look at the raw data from that study, here is 98 women who did develop preeclampsia. If you look at this cutoff level of 38 for that ratio, there's a lot of women with a ratio below that level who did develop preeclampsia within 4 weeks. Our unit's policy has been that because we have a set-up day assessment unit to assess these women when you send them to us and assess them readily and rapidly, that we don't really need to use this test. It's probably very useful in some other settings, and we can perhaps talk about that later. So just to summarize, what's preeclampsia? Well, yes, it's high blood pressure emerging in the pregnancy. So the woman was normotensive at the start of the pregnancy with one or more of the following, and it might be proteinuria in 3/4 of the cases, or it could be kidney injury, liver involvement, neurological or hematological, or evidence of uteroplacental dysfunction such as fetal growth restriction. So any of those things will define the diagnosis of preeclampsia. Okay, let's think about a very similar case. Same scenario at the start of the pregnancy. We get to 26 weeks. The blood pressure is around this fairly mild but elevated level. Same sort of parameters, baby as well. The urinalysis is normal this time. So what do we say this time? What sort of diagnosis can we give? Well, we do the blood tests because we've already learned that 1/4 of the cases will have no proteinuria but can be preeclamptic. And these blood tests are normal. You need to get these results the same day. It's not the sort of thing we can wait to get back the next day. So we need to liaise with the lab on that. She actually has what we call gestational hypertension. So that's elevation of blood pressure. It's a new onset high blood pressure, but there are no other features at all of preeclampsia. So the question is, does this matter? And it does matter because this condition is new onset. It's happening in the second half of pregnancy, and while there are no actual features of preeclampsia, there is a 25% risk that as the pregnancy progresses, gestational hypertension will transform to become maternal preeclampsia. So we can't just say to this woman, you've just got some mild hypertension, don't worry about it. We do have to monitor for all of the things continually, assuming that preeclampsia might emerge. Now, if it doesn't, we can delay delivery until term, provided everything is reassuring. And you'll hear later about when to deliver for women who've got preeclampsia. Here's another scenario that you will get. Same sort of start of the pregnancy, mild hypertension when she comes to see you with shared care at 26 weeks. You're very happy with the baby, the urinalysis is normal, the blood tests are normal. You quite appropriately send her to the hospital day assessment unit. Most obstetric units in Sydney will have a version of that. And then they send her back and they say, look, her blood pressure was good, 120 on 80. She didn't have any significant proteinuria and her bloods were normal. So what would we call this? Well, the first point is this is not white coat hypertension, because white coat hypertension doesn't suddenly just develop. It's something you bring into the pregnancy. What this is called transient gestational hypertension, meaning that it's a blood pressure that went up when you saw her first and then it resolved without treatment. We used to think this too was not much to worry about, but we now know that there's a 40% risk that either preeclampsia or gestational hypertension will emerge. So this woman needs to be seen more frequently in the pregnancy than she otherwise would. So who's most at risk of actually getting the serious condition, which is preeclampsia? Well, there are some major and there's some less common risks. If you've had prior preeclampsia, that's your major risk. Chronic hypertension, you've got a high risk as well, possibly as high as 25%. Multiple gestation, twins, etc. if you've had diabetes pre-pregnancy or if you're obese. And then there are some less common causes. Obviously, it's more common in first pregnancies, but these are probably less common in terms of overall risk than these other ones at the top. So let's go to another case. This is a 26-year-old woman who's overweight, comes to see you at 12 weeks, previously well, and this is the blood pressure you find at 12 weeks, 146 on 98. And her question and your question is, should she start antihypertensives? Now, we need to start out by noting that 1 out of 4 of such women will have white coat hypertension, because this is something you bring into the pregnancy. It's not something that you develop in the pregnancy. So if you have 24-hour ambulatory monitoring available, that is the ideal. If you don't, then home blood pressure monitoring is the ideal. And there are various parameters that we use, but by and large, if the awake blood pressure is less than 130/80 for the home blood pressure monitoring, then this woman has white coat hypertension. Now, again, that is not a benign condition in pregnancy. The risk of preeclampsia is about 8%, and that's double the risk for a normal pregnancy. Now, if when you do the 24-hour monitor or the home blood pressures, you confirm high blood pressure at home, and note that the levels are lower for home reading than in the office. So above 130/80 in early pregnancy on a monitor would be abnormal. Then once you've diagnosed that, her risk for preeclampsia is 25%. And that's why we think it's justifiable putting women with white coat hypertension or chronic hypertension onto low-dose aspirin. Now, in practice, most women who've had some form of hypertension at some stage will have access or have their own home blood pressure device. And there are a myriad of different devices out there, and we can't tell them all to go and buy just one of the 5 that I showed you before. So we did a study looking at the multiple different devices, and basically to say that about 70% of the time, the device will be accurate to sphygmomanometry, which is the gold standard. But about 30% of the time they won't, and that's why it's important to get the woman to bring her monitor to you to compare that in your office, or if the obstetric unit has the service to do that there. So I've mentioned about white coat hypertension. You don't need to treat them with antihypertensives in the office, because in fact, all you're doing is lowering a blood pressure while they're in the office, and then they're going to have even lower blood pressures, which is potentially dangerous when they're outside of the office. But do remember that there's an 8% risk of preeclampsia and perhaps as high as 50% risk for true gestational hypertension. So they need a lot of surveillance. They need to be doing home blood pressures all of the time. Okay, another case. So 12 weeks, blood pressure 115/75. She has her usual blood tests at 12 weeks and comes to you crying after having a report that says she's high risk for preterm preeclampsia and she should take aspirin. And she's also been charged a lot for this. Now, should she have had the test is the first question, and what would you advise now? And I think now, in terms of that first question, when you are ordering this as part of shared care or routine care, we do have to discuss that they may be offered blood tests and ultrasound tests and maternal risk assessment for early onset preeclampsia. I'm not going to go into all of the details of this study, but this is a study published 3 years ago now. The study is very well done. There's no question of that. It's how we interpret it and apply to our population that is the question. First of all, 27,000 women had to be screened in this study. Almost 3,000 were considered high risk for preterm preeclampsia. And at the end of that day, the number of women who developed preeclampsia was, in the scheme of things, pretty low. This test combines maternal factors, the mean arterial pressure when they have the ultrasound, the uterine artery pulsatility index, and some blood tests, PAP-A and PLGF. And then it's plugged into an algorithm. And if the mother is considered at a risk of more than 1 in 100 for preterm preeclampsia, she is offered aspirin 150 milligrams at night up until 36 weeks. Now, it's a very reasonable thing to do. But if the mother's already got the risk factors we talked about before, then she's going to go on to aspirin anyway, so she doesn't need to go through all of this test. And the other thing is, like any predictive test, be it this or be it even a PSA test in a man, you have to be counselling about what the likely outcomes might be and what it might mean. Because about 96% of the women in this group considered to be high risk did not develop preeclampsia, but they would have had worrying pregnancies. I won't go through this too much, but only to make one point about this study. We don't really know what the outcomes were for the exclusion of women who had already had known high risk factors. In other words, if we did this study and didn't include anyone that was considered clinically at risk for preeclampsia, what would we have found? So in practice, how to interpret this study? Well, I think a reasonable way is if you're already considered high risk for preeclampsia, don't do the test because you already know that you're going to be putting this woman on aspirin. And bear in mind, what the test predicts is an increased risk above 1% of developing preterm preeclampsia. The vast majority of preeclampsia, 3 out of 4 cases, are term. On the other hand, once the woman has been informed, it's okay to do the test if she's prepared to use aspirin, which we consider generally safe in pregnancy, and she's appraised of the low likelihood risk overall, and she understands that. So it's important to really have some counselling around that before the test is done, because it does, in our experience, have the capacity to generate anxiety. So to finish up in summary, we've either got hypertension known before the pregnancy or present in the first half of the pregnancy and confirmed by home readings or ABPM. And that's chronic hypertension or white coat hypertension if it's not confirmed. I'm not going to talk about this one today. And then more commonly, we get hypertension arising after 20 weeks, and it can be this phenomenon of transient gestational hypertension, and that carries a risk. Gestational hypertension, which carries a risk, or preeclampsia, which is the more serious of all of these conditions. So I hope that we've quickly whipped through which women we can consider at risk for preeclampsia. I hope that we can see how to classify and diagnose the different types of hypertension in pregnancy now, dividing particularly into the early part of pregnancy and the later part of pregnancy, and which simple tests to use, the creatinine, the full blood count, etc., and more particularly why we do those. So I will leave it at that and be very happy to answer any questions.
Oh yes, hi, it's Karen here. There was just a question come through that says, with the diagnosis of hypertension, is it the rise in blood pressure compared to the booking blood pressure relevant, or is it simply with BP being greater than 140/90?
Yeah, that's an excellent question. Once upon a time, we used to consider a rise of 30 systolic or 15 diastolic as defining hypertension. Now it's just considered to be 140/90, but your point is really well made. If someone's got a rise of that level, 30/15, you should really take notice of that. We wouldn't put a label on them. We wouldn't say they've got definite hypertension, but you'd bring them back more frequently for checking and waiting for them to emerge towards that 140/90 level. That's a good question.
And another question is, should women over the age of 35 years be offered pre-eclampsia screening?
I think the question about the preeclampsia screening, if we're referring to the algorithm I showed with the mean arterial pressure, the blood tests, and the uterine artery pulsatility index, I think that should be offered to people of any age, provided that, number one, they haven't already got risk factors. And I guess what you're getting at with that question is, over 35, do you have an increased risk for preeclampsia? You do, but it's not a group in whom we would automatically say you need to go on aspirin. So really it would be anyone regardless of age, provided they're appraised of what this test really means. And I think, you know, if you've got an otherwise healthy woman, her chances of having early onset preeclampsia are 1% just by getting pregnant. Her chances of having late onset preeclampsia are 3%. And we need to talk around those levels that this test might detect a higher risk, which would in the study was about 4% instead of 1%. But that means there's a lot of women who are not going to go on to get preeclampsia. Aspirin is quite safe, and if they're prepared to take that and understand those risks and have increased monitoring, I think that's absolutely fine. But it all comes down to the proper counselling of the women at the start.
And I think this final question, probably you've answered it, but they were just clarifying, if a woman who has a BMI greater than 30, should she be on aspirin from the beginning of the pregnancy due to being at high risk?
Yeah, that is a good question. And I think whilst we haven't got any fabulous controlled trials to answer that question, I think we're all moving much more in that direction now. Because that risk, when you look statistically at her risk, it's getting up there towards the risks of other high risk groups. So it's a counselling question. It's saying to her, we've put you in one of the major risk categories for preeclampsia. Therefore, we would suggest, if there's no contraindication, to use low dose aspirin. And you can talk about the safety of that in pregnancy and the fact that that gets stopped at around 36 weeks.
Thank you. There are a couple more questions, but I'm conscious of the time, so we might see if we can leave some towards the end as well. So thank you very much, and I will hand back to Lauren.
Great.
Thank you, Professor Brown. I'd now like to introduce our second speaker, Dr. Franziska Pettit, who is an obstetric and renal physician from St. George.
Good evening, everybody, and welcome to this webinar. I'm just going to share my screen and we can get going. So my brief is the management of hypertensive pregnancies, and I guess I focused a little bit on a preeclampsia case, mainly to give you in primary care an idea of what happens to these women when they come through the hospital system, because they obviously come in, are sucked up by the hospital system, and you might hear about her at the very end of the pregnancy when she's already delivered and perhaps is quite a little while since she's had her baby. As we've heard from Professor Brown, hypertension in pregnancy is not uncommon, and it comes in a variety of shapes and sizes, as do the mothers who bear these babies in these pregnancies. But it is associated with significant maternal and perinatal morbidity and mortality, both physical and to a certain extent psychological. And I think we forget that, you know, we discharge these women back to your care, and you end up dealing with a lot of these consequences, which Professor Davies will discuss a little bit later. So a lot of what we do is, everything we do is evidence-based, and I suppose we're mostly guided by these guidelines and the International Society for the Study of Hypertension in Pregnancy. The reference was also seen by in Professor Brown's talk, the more local SOANS guidelines. And we at St. George, and I appreciate that there are general practitioners outside of our local health district, but we do have a website which is on the internet and can be accessed by many, and we have all our protocols and guidelines on this. And this is what bases our management of these women, both in and out of hospital. So I'm going to take you through Rita's pregnancy. Rita is fictitious, but is certainly reflective of many of these women that we end up seeing in our high-risk care and who've come from either shared care or lower risk pregnancy settings. So Rita, this is her first pregnancy. It's all been going very well. She was never considered particularly high risk. She's now 32 weeks gestation, and as mentioned, had a pretty good booking blood pressure. It was deemed uneventful. She didn't feel particularly sick, you know, really thought things were going smoothly, had a normal glucose tolerance test, so didn't have diabetes, and both her 12 and 19-week ultrasounds were considered to be normal. So she presents for her routine antenatal visit. That could be with yourselves or through one of our low-risk antenatal clinics locally. And she does note, she's been noticed to have some ankle swelling, but you know, it's been hot and she's been told that pregnant women can get swollen ankles in pregnancy. But a little more concerningly, her blood pressure is now elevated at 146 on 94 millimeters of mercury. And she has her urine dipped appropriately so in the context of this visit, as every visit should have their urine dipped, and is noted to have 3+ protein. She also mentions that, you know, she has had a headache on and off, but wasn't really sure whether this was related. And I guess at this point, again, similarly to how Professor Brown thought, what are we thinking and what are we going to do? And I guess given that this lady is out of hospital, and you are concerned given the combination of hypertension and proteinuria, so you make contact with her your local delivery suite and ask for her to be reviewed. A good idea to ring up. They don't like people turning up, and you can also ask for some advice. But you know, you've now told Rita she needs to go there, and she's a little bit worried. And when she goes there, blood pressure stays up, and she's been confirmed to have true proteinuria in her urine. So the protein to creatinine ratio confirms that she has proteinuria, as discussed previously. She has normal blood tests, which is reassuring, and also from what we can tell from the CTG, this baby seems reasonably happy. So the question at this point is, what should we do with Rita? Do we send her home? Do we keep her? And really, because we know that preeclampsia is a condition that can evolve very rapidly and in an unpredictable fashion, it is advisable to admit these women on their first presentation with preeclampsia to get an idea and a feel for what this disease is going to do in this woman, and every woman is different. So she is admitted to hospital, and her case is discussed with, at St. George, we call the high-risk obstetricians the RAP team, and the obstetric medicine team, or the renal obstetric team, is the OMC team. And we have consultants from both on call, and her case would be discussed with both of those. Of course, at this point, Rita is extremely worried. Her low risk, normal, happy-go-lucky pregnancy has become a little less so. So preeclampsia can evolve quite rapidly and unpredictably, as I've said, and most stable women, but those who are stable after a hospital admission are those women who have a suspicion of emerging preeclampsia rather than having the diagnosis made, can be managed in a day assessment setting. So we call this our day assessment unit. The Royal Hospital in Randwick, for women, they call this their day stay unit. A variety of hospitals have alternate names, but every setting with a high risk pregnancy service will have somewhere for these women to be assessed and managed as an outpatient. We always advise women on what symptoms they should present with, specifically sustained headache that doesn't go away, visual disturbances, loss of vision, loss of portions of their vision, upper abdominal pain, or generally, if they're really not feeling very well, they should report those. And then, as we discuss a little bit later in more detail, the delivery will depend on the gestation of this pregnancy and the maternal and fetal condition. And I will go in more detail on how we decide whether to deliver these women. So Rita comes into hospital and her blood pressure really continues to be quite high. And we do treat these women relatively aggressively with antihypertensives. We have good evidence from the CHIPS trial, which supports that tight control of blood pressure in pregnancy leads to better outcomes, particularly fewer episodes of severe hypertension, and doesn't compromise the well-being of the baby. So there is this concern that treating the blood pressure may in fact have an adverse effect on the fetus. This has not been borne to be the case, and in fact there's evidence that the pregnancy can continue for longer if we can avoid these episodes of severe hypertension. She's told to take this tablet 3 times a day, and when I go on to describe these tablets, we can see why they have to be taken so frequently. And Rita, of course, is worried because all her friends have told her that, you know, she shouldn't be taking medicines. She's been really careful about what she's eating and drinking, and to take drugs or medicines really seems to be contrary to how she thinks her pregnancy should be going. She has bloods done, not every day, but a couple of times a week during her hospital admission to ensure that she's not developing further organ complications of preeclampsia. And at this point, she would have another ultrasound. So ultrasounds are done in these women who are admitted, and also those who are being monitored as an outpatient, to assess whether there is in fact uteroplacental involvement and any evidence of intrauterine growth restriction. So this baby is a little bit small. She's on the 14th percentile, so not quite got intrauterine growth retardation, but certainly is not a big baby. But because Rita is stable, her blood pressures are sitting less than 140/90, and it is important to not over-treat these women. So we keep their blood pressures somewhere between 125 and about 135, with diastolics between 75 and 85. So certainly not tight control, but definitely some control of the blood pressure. So this day assessment unit, as I mentioned, it's called different things in different places. And generally, this is somewhere where you can send women who are considered at risk in the sort of second half of pregnancy. As mentioned by Professor Brown, if only we could predict, and we have shown that good clinical assessment with a physical examination, a good history, and some very simple tests perhaps can help us predict if this particular woman is going to develop further complications. It's good because it avoids hospital admission, as the last thing you really want to do to a woman in the 32nd week of pregnancy is keep her for the next 8 weeks. Which would not be the case, as I'll discuss, but still it keeps her as an outpatient. We'd like to envisage it as a spa-like environment where the women can relax in reclining chairs, and they have their CTGs done in comfort. They have seated manual blood pressures, as outlined by Professor Brown earlier, bloods and urine. If they need an ultrasound, that can be facilitated there, and it's really essentially a one-stop shop where they have all these things done, and they get seen by both a consultant obstetrician and a consultant renal physician. And I think this is an important fact, that these women should all be managed at a consultant level. Yes, with registrars who are learning, but decisions and management plans should be made at a consultant level. I think I'm not going to repeat all of this, but how we measure blood pressure is critically important. Cuff size is important, and a rested seated woman is really essential. She can't half be lying on the recliner. She must be sitting. And we use carotid cuff sound 5, or the absence of sound, for a diastolic value. So when it comes to medications, gosh, this is a bit of a minefield, and I'm sure you're feeling this in primary care as well, with the changes that have come about with the agents available to us. So 12 months ago, this list of medications would have looked somewhat different, and it is quite challenging when drugs that we have been familiar with for many decades are no longer available. Currently, labetalol is our first agent of choice, and I think across many districts, labetalol is and has been the first drug of choice for a long time. It's not terribly potent, and therefore, you know, starting with 100 milligrams twice a day, 3 times a day, is certainly a low dose. Women think it sounds like a lot. It's a low dose and can be up titrated to 300 milligrams 3 or 4 times a day. Usually going above that, you sort of don't get much bang for your buck, and it's probably the most that the women can take. Our second line agent, or our first line for those women with asthma, is methyl dopa, and really 200 then to 500 milligrams 3 times a day tends to be the maximum that these women will tolerate. It's not clean, it can cause a lot of drowsiness, and certainly has issues in women who may have any evidence of the peripartum depression or anxiety, so need to be careful there. Hydralazine, again, is effective, but has associated side effects, and women don't always love it, can give them headaches, but is our third line agent generally. We don't use a lot of prazosin or mini-pres. It's not, we use it if we have to, but it's certainly not first line. And nifedipine was an agent that we liked because it was once and twice a day dosing. However, this drug is on the way out, if not already gone, and really we're no longer prescribing it first line because women are finding it difficult to get. Once these women have delivered, we used to use a lot of captopril, as you may have seen. We no longer have captopril available to us, so we use enalapril as our ACE inhibitor of choice. Other units do use perindopril, and it's probably also just as safe. I guess I've always been told by my mentors, you use what you're used to using, and then that's the drug that you use best. So this is what we use. But all of these drugs are safe, if not, you know, if we don't overcorrect the blood pressure. And as I said, enalapril is an ACE inhibitor, so we don't use that in pregnancy. How often we adjust these? So we say in admitted patients, we don't adjust more frequently than 24 hours. So we don't change the dose based on a single reading. Blood pressure is variable, and that's why these repeated readings help us make our diagnosis and help us manage these women. We love home blood pressure monitoring, especially in women with white coat hypertension, but only using a validated device. And all hypertensive women should be managed in a high-risk clinic, whether they bring that hypertension into the pregnancy, as I'll discuss, or those who develop it in pregnancy. So back to Rita. So she comes to our day assessment clinic 3 times a week, and initially things are really good. She has a little bit more antihypertensive therapy, and she's so worried about all these tablets. She's now 36 weeks, and her liver function tests have become abnormal. So this is a new worry, and she comes into hospital. So in hospital, we use the standard maternity observation charts to manage to monitor blood pressures, and this is all now automated. And available essentially anywhere where we can log on. We do 3-hourly blood pressure monitors with the liquid crystal sphygmomanometer. 3-hourly. Personally, I don't think we should wake a woman at 3 a.m. to measure her blood pressure, but it is 3-hourly in those other times. And as I said, it's average blood pressures with sustained blood pressures over 150/90 and severe hypertension being defined as 160/110. Our management of particularly of severe hypertension is protocol driven, and the protocol is available on our website, but it is important that each unit and how we manage these women is based on a protocol. It should not be ad hoc. It shouldn't be what you sort of feel like giving now. And it is also fair enough to be calm and to wait for this blood pressure to come down. Anxiety will play a role. If everybody is anxious, then the blood pressure is going to come down slower, but you can take, you know, an hour or two for the blood pressure to come down. It doesn't need to come down immediately. In pregnant women who are still pregnant, you should monitor the baby using a CTG while you're treating severe hypertension. When we do a dipstick urinalysis, we do this on every woman every day. Once it's positive and once the protein to creatinine ratio suggests that she has developed proteinuria with proteinuric preeclampsia, we don't repeat that. Positive is positive, unless we specifically request. Sometimes we want to make sure that it's not gone particularly high. We do bloods twice a week, and we use DVT prophylaxis, and any woman who may have been on aspirin, we stop at that point because there is the potential for requiring delivery. In general, aspirin, which we start in women as mentioned, we stop by 36 weeks gestation. So if you're seeing these women and they're still on aspirin and it's coming up to 36 weeks, feel free to discontinue this agent at 36 weeks. As we know, the definitive treatment of preeclampsia is delivery of the baby and the placenta, and it's always beneficial for the mother, and I guess the gestation at which this occurs will determine how good or bad or otherwise it is for the baby. So Rita is in hospital and her blood pressure is quite difficult to control. She has all these rapid response calls, and they keep giving her more and more tablets. Her liver function tests are no better, and now everybody seems to be a bit worried about Rita, and she can tell. She has another ultrasound and it shows that her baby is on the 10th centile and the blood flow is not very good. So at this point, things can happen very quickly. She has had steroids, and we give steroids at 24-hour intervals to women who we think may require delivery. Steroids, particularly if we think that this is going to be an early delivery and even a cesarean section up to about 38 weeks, we give these women steroids, and that's for infant lung maturation. So she's had steroids, and that's a good thing, and realizes that now we're talking about delivery of the baby, and she's only 36 weeks, and she's quite worried about that. But I think we have good evidence that she's getting sick, and it's certainly time to consider delivering this baby. So when we talk about timing of delivery, this is certainly not something that we do with ease, although we have good evidence from the HIPPOTAT study that women with confirmed preeclampsia should be delivered at 37 weeks, and they should not go much beyond 37 weeks, as the benefit to the baby is far outweighed by the risk to both baby and mother after this gestation. Yes, it's early, but it's a risk benefit balance. Other indications for delivery in our own unit with Dr. Louis has looked at specific indications or triggers for delivery in our population, and certainly maternal indications seem to be the highest and the biggest indication for delivery, certainly in term women, with a combination of fetal and maternal indications in those women who were preterm, suggesting much more of a placental disease. But if you cannot control the blood pressure with maximum therapy, it's time to bail. If you've got progressive deterioration in liver or renal function or ongoing thrombocytopenia, which you could interpret as development of the HELP syndrome, it's time to deliver. Neurological signs and symptoms, again, time to deliver. If there's any concern about fetal well-being, either on a CTG and a confirmatory ultrasound, it's time to deliver the baby. with the delivery, the decisions again are made at a consultant level. So when these women are induced, so we do, and this is often a concern that the women have, that we try very hard to induce these women. We don't automatically assume that these women have to have a cesarean, but we do watch them carefully in labor and tend to use intravenous therapy for management of their hypertension, because if they're in labor, they won't absorb the drugs. An epidural is useful for the management of blood pressure, but it is not, you don't make women have an epidural just to help with the blood pressure. What we avoid are routine intravenous fluids, and even we're careful, only use them if needed for the epidural. We record urine output, and we try and avoid agents that may make the blood pressure worse. So Rita is very happy. We're happy for Rita to have an induction. You know, things are reasonably stable. But during labor, her blood pressure goes very, very high, multiple episodes of severe hypertension, and she starts seeing spots in her vision which weren't there before. Her feet are tested, she has her reflexes done, and she notes that these shake, particularly when they check her ankles. So now Rita appears to have developed some significant neurological consequences of her preeclampsia, which leads us to when do we give these women magnesium sulfate. So the MAGPIE trial, which was published in the Lancet quite a while ago, had good evidence for the use of magnesium sulfate in the reduction in the risk of progressing to eclampsia in these women. Far better at controlling the seizures of eclampsia than any benzodiazepine. And this is what Rita got. So we give it after convulsion, if this has happened, after altered mental state, hyperreflexia with clonus, so not just hyperreflexia, but there needs to be clonus, or a combination of other significant neurological symptoms. With severe right upper quadrant pain, which is an ominous sign, we give it. And if the preeclampsia is progressing very rapidly, with very rapid progression in blood pressure, we can give it. Occasionally, we make our first diagnosis of hypertension in labor, and it's a little bit more difficult. And the thing to remember is, if you're in labor, the treatment is happening, let it continue and monitor the woman and make the diagnosis afterwards. There's no urgency in making a diagnosis while the woman's 8 centimeters dilated. Once we have these women in labor, as mentioned, we give IV agents to manage the blood pressure. And there's certainly, once they have delivered, we tend not to withhold agents unless they're very hypotensive or if they have a significant postpartum hemorrhage. So we start everything back once they've delivered the baby. Although we say treating the hypertension doesn't go away straight away and can linger for quite a bit, as we'll discuss at the end. So poor Rita ends up with a cesarean, and her baby Florence is a little bit small at 2.1 kilos, and she needs to go to the nursery for some feeding, and she goes to ICU for magnesium sulfate. This is not routine across all hospitals. Many hospitals have got high dependency units for women on their postnatal ward. Some hospitals, these women go to ICU, and of course, women worry that they'll never bond with their baby. So we generally give magnesium sulfate for 24 hours, occasionally a little bit longer, and we advocate for visits from the baby if the baby can come to ICU for ongoing skin-to-skin contact and breastfeeding. So none of these things are a contraindication to breastfeeding, which is important. We see our women back on the postnatal ward and things go back to 3-hour blood pressures, and we continue the antihypertensives and adjust them as needed. Sometimes the dose goes up, sometimes they can be discontinued. Oh, sorry, door bag. As I said, the antihypertensives we prescribe are safe in pregnancy. There can be a honeymoon period that we try and just ride out, and things generally will go up again. And we only really repeat bloods if there are abnormalities or clinical features determine that. We don't rely on routine, regular blood tests. DVT prophylaxis is indicated even in women with the vaginal delivery, and we try and get these women up, but they stay for 5 days, no exceptions. And this is something that is really important to tell them early, because otherwise they're really upset and shocked that they have to stay. Sometimes the antihypertensives can wean, and we do not use anti-inflammatories, as this can make the condition worse. So Rita actually doesn't really hate being in ICU. It wasn't that bad. She comes back down to the ward and things are looking a little bit better for her. She stays 5 days, and during that time we manage both her and her blood pressure and other features of preeclampsia. Some occasionally women who are at risk of hypertension develop this condition for the first time after they've delivered, and I think in general practice you often see women who had a normal pregnancy without any hypertension and they develop some hypertension once they've gone home. So we investigate and manage this in a similar fashion and treat to the same targets. We readmit these women to hospital if they're already outpatients to establish whether what type of hypertension they've developed and whether they've got any significant consequences. If it's terribly uncontrolled and she has ongoing significant bleeding, there's a concern for retained products, and that would be looked at as well, but is rare. We look for precipitants, and often the lady has taken some Voltaren or Nurofen for pain, or has had some decongestants because now she's no longer pregnant. She can have them and her nose is all blocked. So these can precipitate hypertension in the postpartum period. So we send women home even if they're still on their antihypertensives, because we know that it can take a long time, up to 3 months, even longer, for the blood pressure to settle. Occasionally, these women are sent back to your care on enoxaparin or for management of nephrotic range, or if they've got lots and lots of proteinuria and are at risk of DVT, then we do send them home on Clexane. And there's ongoing counselling about avoiding non-steroidals. So who follow these women up? So generally, as you probably are aware, that all those women with uncomplicated term preeclampsia, gestational hypertension, essential hypertension, generally we ask them to see you in general practice for regular blood pressure checks and a check on and a urinalysis to ensure that the proteinuria has resolved. The women that we see back in our obstetric medicine clinic tend to be those with either very early onset or very severe preeclampsia, or those with some unusual features that makes us worried. We often see women back when we consider that maybe this woman might have underlying hypertension. And you saw with Rita, her booking blood pressure with a diastolic of 82, perhaps not entirely normal for a young woman in her first pregnancy. They have counselling for their next pregnancy and the long-term risks, which Professor Davis will talk about. As I mentioned, Rita goes home, and Rita is worried about, her next pregnancy, what's going to happen in her next pregnancy. And we know that women who have had preeclampsia in their first pregnancy, those women who have had early onset disease like Rita, have about a 25% chance of developing this in her next pregnancy. Those women who have later onset disease have a lower risk of between 10 and 15% of developing this disease again. But these women are considered higher risk for future pregnancies and will no longer be suitable for shared care or low risk antenatal care. So she sees you in a week, and decisions are made about reducing her antihypertensives, and tends to happen sometimes very quickly, sometimes more slowly. She comes back to see us in 6 weeks. So with Rita, we would see her because I'm not convinced about this diastolic of 82. And we tell her that she might have high blood pressure outside of pregnancy, which we confirm as mentioned with an ambulatory blood pressure monitor. So we see these women and we screen for an underlying cause. So generally we look for any evidence of autoimmune disease such as lupus, any evidence of renal disease that may have, or diabetes, which may have precipitated the early onset disease. We counsel the mum as to what happened, particularly with her admission to ICU. And it's important that we get the mums to bring their partners to these visits, because they're often just as worried, if not more worried. They had a lot more to lose with their, baby and wife being sick. So we counsel them about what happened and debrief with them. We advise them about their future risks Give them some lifestyle advice if it's indicated, and always advise regarding contraception, particularly if you're continuing them on an ACE inhibitor. I spoke a lot about preeclampsia, but gestational hypertension and essential hypertension. Gestational hypertension we view on the spectrum of preeclampsia can happen after 20 weeks and is managed generally as an outpatient through a high-risk clinic. Women with essential hypertension are considered higher risk, and their risk of developing superimposed preeclampsia is about 25%. So all these women are deemed not suitable for shared care. They come to a high-risk pregnancy clinic, and depending on where you're working, this might not be your local hospital, such as Sutherland. They may need to come to somewhere like St. George, where we have the facilities and capacity to look after these women. All these women who are considered high risk, and as mentioned, Professor Brown mentioned, they're started on aspirin and calcium from about 12 weeks gestation. We use 150 milligrams of Disprin, so we ask them to cut that in half and discard the second half, because there's evidence that the aspirin can degrade once the tin foil has been opened. And ideally it should be taken at night, but honestly, whenever they can remember it is probably better than forgetting it half the nights. These higher risk women, such as gestational and essential hypertensives, are monitored frequently, about fortnightly from 20 weeks, and after 30 weeks they're seen every week, 1 week by us and 1 week by the obstetric team. And they tend to require more ultrasounds. As mentioned, white coat hypertension, these women have a 40% risk of developing true hypertension. So we watch these with their home blood pressure readings, also through a higher risk clinic without needing antihypertensive therapy specifically. These women don't need to be delivered early, but generally we like them not to go post their dates. So a planned delivery between 39 and 40 weeks is reasonable. And they're always considered high risk for future pregnancies, even if they just had gestational hypertension. And we know from when Professor Davis will talk to us about, even those women have high risks in the future. Finally, these women, before they go home, we invite them to participate in ongoing studies that we have, because we can only guide the care of these women based on the evidence that we get through studies. And we always encourage women to participate, and there's certainly one study running at the moment, the BP squared study, which extends beyond the St. George Sutherland area and includes the Royal Hospital for Women and RPA, as well as Liverpool and even Westmead. So all women that have a hypertensive pregnancy are invited to participate in this study, which looks at lifestyle modification for these women in an attempt to reduce not only their risks in the future pregnancies, but longer term as well. And that's it.
Okay, thank you. We have a couple of questions. One question was, is supplementing with magnesium recommended at all during pregnancy for these women?
No, we don't recommend giving oral magnesium to prevent eclampsia or preeclampsia is not recommended. We do use calcium in conjunction with the aspirin, as it augments the benefit of aspirin, but not magnesium. Some women take magnesium for cramps, but that hasn't been shown to reduce your risk of developing preeclampsia with neurological involvement.
Thank you. And another question around calcium. There were two questions, why are patients prescribed calcium, and what is the dose of calcium for preeclampsia?
So all of these things, the aspirin and the calcium, so they certainly don't, so the calcium augments the aspirin. So we use it in conjunction with aspirin, and particularly, and the evidence is more so for those women who have a diet which is low in dietary calcium. And I guess that's obviously, sometimes it's a bit objective. We don't really know how much calcium these women are taking, but in general, our population is very Asian, and a lot of Asians avoid a lot of dairy products and tend to have a lower calcium intake. So in these women, it has been shown that supplementing with calcium can further reduce the risk of early onset disease. So the aspirin is specifically to reduce the risk of early onset disease, which is obviously the most significant. So, and the dose, look, we tend to use 2 600 milligram tablets, so 1.2 grams for this, unless, you know, the woman says, well, all I've been able to eat and drink since I've fallen pregnant is milk. So, but generally that's the dose that we advise, and we ask them to take it at whatever time they're taking their aspirin.
And just one final question, I'm conscious of the time, is for women that are switching from their regular antihypertensives to safe ones during pregnancy, is there a specific time that that should commence?
Look, it's variable. So some of the women that we see in our sort of renal outpatient clinics, if they're dependent on an ACE inhibitor, particularly for management of proteinuria, a lot of these women, we allow them to stay on their regular antihypertensives until they fall pregnant, with the proviso that we're the sort of second person that knows that they're pregnant. But often a lot of these sort of more metabolic women, it's much better to switch them beforehand if they're not going to be that reliable. And will often depend on the severity of the hypertension. You know, you don't need a weaning off period, if that's what the question was. So you can stop the ACE inhibitor, the angiotensin receptor blocker, start something else and fall pregnant. Although it is nice to know that the blood pressure is controlled before falling pregnant. Some of these women, or quite a few of these women, come to us for preconception counseling or management of the hypertension if there's anxiety and switching. And sometimes it can be a little bit, you know, none of these agents are as potent as a good dose of an angiotensin receptor blocker, so it can sometimes be a little bit of trial and error. So switching them is fine, and then up titrating, and if you're struggling, get some of us to give advice, but you don't need to wean them off or to have a washout period.
Thank you. We have got a few other questions, but we might leave them till the end to see if we've got time for the three presenters to maybe answer them. So I'll hand back to Lauren for the next presenter. Thank you.
Thank you.
Thank you, Dr. Pettit. I'd now like to introduce our last speaker, Associate Professor Greg Davis. He's also an obstetric and renal physician at St George Hospital.
Hi, can you hear me?
Yes, we can, Greg.
And I'd just like to say that I'm not a physician, I'm an obstetrician. Can you hear now?
Yes, all good, Greg. We can see your presentation as well.
Fabulous. So look, I'm going to talk about the next pregnancy and the long-term implications of the hypertensive disorders in pregnancy. So I'm also going to start with, I hope, we're talking about our first learning outcome is to recognise women at risk for recurrent hypertension in pregnancy. So a woman, Sally, she's a registered nurse and she's had one baby before. She had Pre-Eclampsia and had a cesarean section at 37 weeks, but was on Methyl Dopa for 9 months postpartum. She had a 24-hour monitor after birth, which was normal. It did show white coat effect, but she has no other history. In a second pregnancy, she presents at 9 weeks. She's overweight with a BMI of 32. She's hypertensive with a blood pressure of 142 on 82, but she has a normal examination and only trace protein in her urine. So her question is, what will happen in this pregnancy, doctor? And will I get preeclampsia again? Now I'm just going to take you through this slide. This was some work that Prof Brown published on looking at hypertensive disease in pregnancy at St George Hospital, and on the y-axis we have percentages. On the x-axis we have their diagnosis in their first pregnancy. So we have gestational hypertension, overall preeclampsia, non-proteinuric preeclampsia, proteinuric preeclampsia, and normal. And so this is what happened in their second pregnancy. So if we look at the normal column first, almost all the women who had a normal blood pressure in their first pregnancy will have a normal blood pressure in their second. If we now look at preeclampsia, if they had preeclampsia in their first pregnancy, they had a 14% risk of gestational hypertension in the crosshatch bars here, and a 14% risk in preeclampsia. And then if they had gestational hypertension, they had a 26% risk of gestational hypertension in the second pregnancy, and a 6% risk of preeclampsia. So summary of that, there's about a 30% risk of recurrence in subsequent pregnancy. They have a higher risk if they have severe disease in the first pregnancy, and we'll talk about this: early onset hypertensive disease, HELP syndrome. If they had an elevated booking blood pressure in the second pregnancy, which Sally did, if they have underlying risk factors like increased BMI, they've got underlying hypertension, or twins. But I think that the take-home message really is that 70% of these women are likely to have a normal subsequent pregnancy. So how can we help Sally in a second pregnancy? And the other two have already mentioned this, but our second learning outcome is the preventative treatment for at-risk women in their subsequent pregnancy. So these are the ISHIP guidelines, the International Society, which Mark was also the lead author on. So low dose aspirin, preferably starting before 16 weeks until 37 weeks, 100 to 150 milligrams daily. So if they have one or more of the major risk factors for preeclampsia, so Sally has prior preeclampsia, she may have chronic hypertension, she's certainly got a BMI over 30. Or if they've got two or more minor risk factors, which are listed there. The guidelines don't include assisted reproduction, but that's certainly on everybody's list now if they've had an IVF or donor egg pregnancy. People were asking about calcium. These are the recommendations: 1200 milligrams a day if dietary calcium intake is low. And Franziska mentioned Asian women, many of whom are lactose intolerant, so have very little dairy food. And also reminding you that a lot of women in early pregnancy will not be taking dairy either. Interestingly, aerobic exercises tends to reduce the incidence of hypertensive disorders, but they have to be exercising, as you can see, quite significantly for many women in pregnancy. So our plan for Sally's second pregnancy is aspirin was commenced at 12 weeks and ceased at 36. Calcium supplements, and she was monitored between an obstetrician and a physician because she was a private patient. So she was seen at 36 weeks and she'd had normal blood pressures, she had no symptoms, no proteinuria, fetal growth seemed normal, her uric acid was normal, and we don't use uric acid now for diagnosing preeclampsia, but it's a good indicator if it's low that she hasn't got it. And similarly, if it's raised, it is a concern. However, 2 weeks later, she's developed preeclampsia, so a spot protein creatinine ratio of 56, and we consider above 30 to be abnormal, as Prof Brown said. She was started on oxprenolol, and she had another cesarean section of a very healthily grown daughter, and was continued on oxprenolol. She recovered, but her blood pressure was still elevated, and she stayed on oxprenolol for 2 months, but she came back to see a GP at 6 weeks, and her urine dipstick was negative. So in summary, she had a first pregnancy, she had late onset preeclampsia, no IUGR, but a prolonged requirement for an antihypertensive. In a second pregnancy, again, very similar, late onset preeclampsia, no IUGR, but milder this time, only needed oxprenolol for 2 months. So is preeclampsia an illness that completely resolves by 3 months postpartum, as we were all taught at medical school? And what are the long-term issues for Sally? So our third learning outcome is to understand the long-term implications of the hypertensive disorders of pregnancy. And these are some risk factors. So these are quite chilling statistics, I believe. And in terms of the references, I've got a reference list at the end, so that will be on YouTube or whatever this is put up as. So chronic hypertension, 3.7 times the risk of a normotensive woman. Ischemic heart disease, 2.5 times. Stroke, 2 times. Cardiovascular death, 2.3 times. Venous thromboembolism, 1.8. Type 2 diabetes, 3.1. And although it's rare, end-stage kidney disease, they actually have a 6.3 times risk of end-stage kidney disease. And if you compare this to the normally accepted risk ratios for cardiovascular disease in women, they are a much higher degree apart from diabetes. And in the early 2000s, mid-2000s, there were a number of meta-analyses were published looking at the cardiovascular sequelae, and these are what I'm going to concentrate on. So in this one, a very well-known study, 116,000 women with pre-eclampsia or eclampsia and over 2 million normals. And you will see the cardiovascular sequelae, ischemic heart disease, congestive heart failure, myocardial infarct. And if we look at the relative risk, overall it's 2.33. And cerebrovascular disease, that figure is 2.03, so 2 times the risk. And this is a very interesting slide. So this was another big study from Utah looking at 60,000 women with hypertensive disease and then doing survival curves. So the black line is the normal woman. The green line is those who had eclampsia. The brown orange line is those that had preeclampsia. But the blue line, which is the worst outcome, is for women with gestational hypertension. And so I think it really underlines how important it is to take gestational hypertensive disease importantly as well. If we now look at what's happening in New South Wales, this was a big data linkage study that Amanda Henry from our group was involved in, 528,000 women, and they were looking at the 10-year risk of hospitalisation or death from a cardiovascular event, so either ischemic or hypertensive, heart disease or stroke. And the main finding was this was 2.1 per 1,000 women who were normotensive and 5.5 per 1,000 after hypertensive disease in pregnancy. But the risk increases over time. So at 5 years postpartum, it's 1.8 times. 10 years, it's 5 times. And at 15 years, it's 11.8 times the risk of a normotensive woman. And there are a number of independent risk factors. So early onset hypertensive disease, that's less than 34 weeks. Preterm birth, and preterm birth in this scenario is really an indicator of severe preeclampsia because it's iatrogenic. We deliver the babies because either the mother or the baby is at risk. Maternal age, smoking, and social deprivation were all independent risk factors. But the really startling finding was that these risk factors are additive. So a woman with late onset hypertensive disease has 2.5 times the risk. But if a woman had early onset hypertensive disease, is a smoker and had a preterm birth, she had 49 times the risk of a cardiovascular event. And this is shown graphically here. So up here we have the rates per 1,000 and have time along the bottom. In the pink we have the normotensive woman. In the blue it's the late onset hypertensive disease, and the green is the early onset hypertensive disease. And it's a dramatic demonstration of that. And if you look down the bottom here, in early onset disease at 15 years, a woman has 24.5 times the risk of a cardiovascular event. And to give you some idea of the number of women this involves, in New South Wales every year there are 95,000 births. And so early onset disease is only 0.04% of all births, but that's 43 women a year in New South Wales, most of whom will be in Sydney. So there's going to be a lot of these women who are at very high risk. Now, what does our research show? We have been involved in this area now for almost a decade. And just a bit of light relief, this is our medical core here. That's Professor Mangos there, standing between myself and Franziska, Professor Brown and Professor Amanda Henry. And if you look at the background there, this is the ISHIP meeting in 2016 in Sao Paulo, Brazil, a place that I'm sure none of us will ever be going back to. And you can tell who were the presenters on that day. Some of you may have heard of this study that we've been running recruiting for since 2013, the P4 study, which is looking at women 6 months postpartum and looking at their physiology, their psychology in the babies, and comparing normotensive and hypertensive women and following them up again at 2 and 5 years. So these are the results. So this is looking at the booking visit with their GP, and you'll see that there were 302 normotensive women and 90 with preeclampsia. So if you look at the means for BMI, systolic blood pressure and diastolic blood pressure, the preeclamptic women were those women who are destined to develop GH or PE, begin the pregnancy with a higher blood pressure and BMI. But important to realise it's within the normal range. And our main finding, and really what the message that we are trying to promote, is that the upper limits of normal blood pressure, so this was in the normotensive woman, was 122 on 79. So in a normal woman postnatally, this is the upper limit of normal. So if you then look at women who have a history of preeclampsia in this study, looking at the table here, if you use the old measure of 140 on 90, none of them would have had systolic hypertension, and only 3.3% would have had diastolic hypertension. However, if you use the new figures of 122 on 79, 13.3% had systolic blood pressure, right, were above the systolic mark, and 18.9% were above the diastolic, which means that 19% of women with a history of preeclampsia will have an abnormal blood pressure at 6 months postpartum. And we believe that this is the group that we should be focusing our attention on. The other differences at 6 months, so lipids and insulin resistance, you'll see there are significant differences. We haven't looked at these figures to see whether there's any particular cutoff, but that remains to be done, but they are certainly significantly different. So our fourth learning outcome and final one is screening women with prior hypertensive disease in pregnancy for modifiable risk factors for cardiovascular and renal disease. So this is our proposed schedule. It hasn't been promulgated anywhere as yet. So that at the 6-week visit, they should have their blood pressure checked, and if it was above 122 on 79, this is considered to be abnormal. They should be advised about their increased risk and asked to return at 3 to 6 months for a screening visit. At that visit, they should have their blood pressure taken, and ideally, as Professor Brown and Dr. Pettit have said, a 24-hour monitor or home blood pressures. They should be screened for metabolic abnormalities, so the BMI check, the glucose and lipids, and have a urine dipstick for albuminuria and proteinuria. They should have an estimation of cardiovascular risk based on their obstetric history, as I've said, early onset hypertensive disease, if they have had gestational diabetes, and other more the usual risk factors. They should be given individualized lifestyle advice, and Franziska mentioned the BP squared study, so we'll hopefully, when the results of this are through, we'll be able to see what is the best way of delivering this advice. because we all understand how difficult it is to get people to comply with these things. We need to advise them about their next pregnancy, and if they are hypertensive or have diabetes, these clearly need treating, and possibly lipid abnormalities as well. And they should be referred to a specialist if necessary. So their ongoing care with their GP should be yearly weight and blood pressure, every other year glucose and lipids, lifestyle counselling and weight management so that you can detect and treat the medical conditions. So in summary, preeclampsia and gestational hypertension can recur in subsequent pregnancies, and this risk can be lowered. There's an increased cardiovascular risk following hypertensive disease in pregnancies, and for a long time, people have realised that pregnancy is a physiological stress test for young women. And the American Heart Association recognised hypertensive disorders as cardiovascular risk factors in 2011. So we have this slightly different model for late onset hypertensive disease, different to the model that Professor Brown talked about earlier on, which is more a placental disease, although the two definitely overlap. So we have here women who have a normal BMI and blood pressure at the start of pregnancy. They'll go on to have a normal pregnancy and will be normotensive afterwards. Then there is this group that are more like metabolic syndrome, who have raised BMI, raised blood pressure at the start of pregnancy, who are more likely to get hypertensive disorders and go on to have these complications that I've outlined. And what we're suggesting is that at 6 months, these women should be evaluated, counselled, and treated as necessary. What we don't know is whether doing these things will make any difference. So just to summarise the GP management after hypertensive diseases of pregnancy, I think my real take-home message, and one that we're struggling to get across to my peers in particular, is the recognition of increased risk after hypertensive disease. They need to be referred early in the next pregnancy. Low-dose aspirin and potentially calcium should be started. If they're not wanting another pregnancy, they need to be strongly advised about contraception, and preferably the long-acting contraceptives rather than the pill if they're hypertensive. They need to be encouraged into a healthy lifestyle, annual blood pressure and weight, biennial lipids and glucose, and to be referred on as necessary. And there's my list of references. So that's all. Thank you.
Thank you. There's just a couple of questions. One question was, why does an IVF pregnancy cause an increased risk of preeclampsia?
That would have to be an excellent question, and they obviously have a number of underlying risk factors, like, why have they not been able to get pregnant? Often, and certainly they are often older, but even when you control for age, there's still an increased risk of preeclampsia in women who've had assisted reproduction. So no one really knows for sure, but it is a very strong risk factor for it.
And there's been quite a few questions about when aspirin should be started. So there's been quite a few people asking when is the evidence for actually starting it?
See them. We know that it's safe. Low-dose aspirin is very safe. It's been given in studies in millions of doses, so we know it's very safe. So as soon as you know the woman is pregnant, you can start her on low-dose aspirin. I don't think it's not an urgent thing to start, but it needs to be started before 16 weeks. So you do the pregnancy test, you make sure that the pregnancy is viable, and then sort of 8 to 10 weeks you can start the aspirin.
Thank you. And just the final question was, is there any data in regards to any impact on child development for mothers that have had a hypertensive disorder in pregnancy?
Again, that's a very good question, and as part of the P4 study, as I said, we have looked at the babies as well. In terms of their development, at 6 months, the babies of the mothers that were hypertensive were actually doing better than those that weren't hypertensive. I suspect that's not going to be sustained in the longer term view, and we've got other people looking further into the pediatric outcomes, but certainly there's no indication that the babies are adversely affected, other than to say that, you know, if the baby's being significantly growth restricted, no matter what the cause of that, there are, you know, that does have longer term effects on the babies. And if in terms of their cardiometabolic side effects, if a woman's had hypertension in pregnancy, the children are more at risk in terms of increased weight gain and small increases in blood pressure as well. So there are some minor effects, but not major effects.